Hi guys, good evening. Can you all see me and hear me? All right, so welcome to the class. Just give me 1 second. I'll share the link. I hope you're all doing well. Studying well. We have finished integrated. So today is the last day, and now we have only 6 subjects left, out of which 5 are short subjects. So if you've been following the schedule, uh, I think you are at very good pace. Even if you're lagging behind, it's fine. But still, thoda bahut, 70 to 80% also, if you've done it, it's great, that you would be completing in the next 15 days. So even if you've just joined and, you're planning to start, it's okay. Nothing is lost in, you can still study really hard and everything is going to be okay, right? So a lot of you have jobs, a lot of you have internship going on. It's okay. What I'm going to do is we're going to have a new schedule. I was thinking I'll do a recorded class, या फिर I will have a live class probably. So on 2nd we will have a class wherein we'll discuss how to go about it now. Yeah, live करेंगे, ठीक है. A unanimous live. Usually we don't agree, but everybody is on the same page here. So we'll have a live session wherein I'll take up your doubts and we'll see how to go about it next. I was thinking 2 different sessions, one for the timetable, new timetable that we'll be having after 15th, and I'll also give you a buffer and how we are going to be doing things. I also have to think and brainstorm ki kya karna hai. How to make the best of it and also not have too much you know too much content which is getting duplicated, because I want you all to I mean, the reason why you are liking BTR and why it's successful is because it's concise and you don't have too much. So if I keep having live classes, it'll again become the same thing that you have too much content to revise, right? So I'm going to make sure that it's not too much, and that's why I rearranged the classes also. I deleted a couple of sessions where I felt you don't have to see because I've covered the content anyways. So you just do what I am telling you and you would be sorted. Don't worry too much about it कि kya karna hai kya nahi karna. You just follow what I'm saying and it'll all be okay. Don't worry. ठीक है. INI, yeah, INI would be, see, because we don't have neat dates. So I think even if you're not appearing for INI, we have to prepare as if November is our target, है ना? तो November को target मान के ही next cycle would be there. So we'll have one more cycle of MCQ. Predominantly we'll be discussing MCQs, and I'm also planning to have one more part to BTR wherein we have a few things that I was telling about. Now there's no next, but still no harm in doing those things which we had discussed about next module. So that's what I'm gonna have for the final year and the third year students, if there are any. So करेंगे बात. So let's talk about all of them. Today is not a day for good things. Today is a day for pharma and path, general pharma and general path. The worst of pharma and path is what we have to do today. Okay, so today is not a day to be happy and have good talk about what to do next and have plans in life. Today is about feeling depressed and feeling like kya hi karna plan ka. So let's see. I have tried my best to make it easy, because for me to teach, first I had to understand, and it's been like too many days that I've been studying ANS, and finally I feel confident that okay, now I can take a class. Okay, so काफी दिन से मैं इसके साथ struggle कर रही थी, but hopefully you will like what I am teaching. If you don't like what I am teaching, I would be completely fine, because this is not a topic which I like, and I would be really happy if you can just study this from GRG sir or whoever you follow in pharma. I would love that. Okay, anyways, but I will try. Okay, so let's see if we can make sense of it. All right, shuru kare fir. Shall we start? Telegram link. Did I not post the Telegram link? I thought I posted. Chalo, ab dekho. PDF is here on the group. Everybody can join if you want the PDFs. All right. It's okay if you're not getting time to do RR from other platforms. Your first target has to be BTR. In this first cycle, your main aim has to be to master and consolidate BTR. All right. So that is what we have to डू। ठीक है, बफर डेज कितने देंगे मैं भी सोचूंगी, अभी मैं इसमें बहुत दिमाग लगाऊंगी हाउ टू डू नेक्स्ट एंड व्हाट टू डू नेक्स्ट, एंड देन आई विल टेल यू ओके कि क्या करना है, कैसे करना है, टू बैलेंस एवरीथिंग, बिकॉज आई डोंट वांट टू बोम्बार्ड यू विथ अ लॉट ऑफ क्लासेस जो आप बाद में रिवाइज ना कर सको. सो आई विल कीप इट बैलेंस्ड, यू नो. लेट्स सी. चलो अभी शुरू करें विथ, विल स्टार्ट ऑफ विथ जनरल फार्मा एंड देन वी विल हैव जनरल पैथ. All right, all things we'll discuss now towards the end if time permits, otherwise in that strategy class अभी पढ़ाई करते हैं. ओके चलो फिर शुरू करें. राइट, हाँ हाँ ओके, आई गॉट ऑल ऑफ योर सजेशंस. अब अपने पास रखो अपने सजेशन. नाउ स्टडी. ओके, नाउ ओनली गिव मी फार्मा आंसर्स. Fine. All right, let's start. So we're starting off with ANS. So in ANS, what you need to remember here, I already posted the link. Okay, now everybody just take this link and don't ask for it again. Okay. I don't know why it's 9th Jan. Again, it's come. One day it was showing correct time. Again, it's back to 9:41. There's something here at this time which has happened in my last janam of life, and it has stuck. For some reason, something went down at 9:41 a.m. 9th of Jan, because in my own personal this life I can't think of anything eventful which has happened. So some other life something must have happened, choki it's coming to me again and again. Anyways, all right, so let's start off. So ANS, we have sympathetic system, we have parasympathetic system. If you're not aware, parasympathetic system we also call it as cholinergic system, and sympathetic we also call it as adrenergic system. All right, so that is what you want to remember as the gross basics. Now when we talk about the system from the spinal cord and the brain, we have two parts, right? We have the sympathetic, parasympathetic. Who gives rise to the parasympathetic outflow? It's the craniosacral outflow, right? So it is upper and ekdam niche. Craniosacral is your parasympathetic outflow. Can you tell me which cranial nerves have parasympathetic supply? This we've done in cranial nerve column, say Virginia, say Vaz. What are the cranial nerves which give you parasympathetic? Correct, it is 3, 7, 9 and 10. You want to see one nice math magic trick, everybody? Okay, so who will tell me what is the common link with 2, 7, 9, 10? What is 2, 7, 9, 10 tell you? What does it remind you of in medicine? Very nice. These are all coagulation factors which are vitamin K dependent, which are activated by vitamin K. 3, 7, 9, 10 we have just seen is the parasympathetic system. Now magic. 2 plus 3 equals 5. So 5, 7, 9, 10 is a part of what? 5, 7, 9, 10 reminds you of what? These are all of the pharyngeal arches, right? So these are the nerves of pharyngeal arches. So this way you can remember 3 numbers together, you know. I love remembering numbers for certain reason, you know, even if they are not asked, but most of the times you do have to remember they're asked. So, you know, you try to bring it all together, and that way, you know, you will remember. Otherwise, this is scattered thing, 2, 9, 10, 7, 5, 9, 10. It's a random nahi yaad rahega. Aise you will remember. Okay, so this is how you want to remember. So this is craniosacral parasympathetic. What parasympathetic is? We'll talk about it. Then we have the sympathetic outflow. So that is obviously thoraco-lumbar cord में से निकल रहा है. Now what you have to remember is सबके पास एक ganglion है, right? You have a ganglion with sympathetic chain. These are the ganglia, and you have a ganglion with parasympathetic chain. Which is longer? What do you think? It is very apparent that parasympathetic का preganglionic neuron is longer, whereas sympathetic cord, you know, it's paraspinal, right? It's just near the spine. So that way you can remember that inka ganglion is so close to the spinal cord that it's going to be shorter, right? So preganglionic neuron is shorter. Okay, so that is what you want to remember. Fine. So this is about preganglionic neuron, and somebody has written ma'am ki favorite book, Telephone Directory. That's very funny. Okay, so this is long and this is short. No, my favorite book for the record to be very studious and correct is Robbins, and that is what we are doing today. So आज बड़े साल बाद Robbins पढ़ के मुझे बहुत खुशी हुई. I went back to neoplasia chapter and I was reading tables and revisiting my favorite book. I really liked it. Okay, anyways, so preganglionic neuron, postganglionic. Now what you want to remember here, that at all ganglia, what is the neurotransmitter? See, we call cholinergic as parasympathetic, right? But what you want to remember is sub में ही preganglionic में acetylcholine is only acting, right? So you can see even in sympathetic acetylcholine is acting, and the receptor is NN. This is very important for your concepts. इसलिए मैं ये एकदम basic first year में जा रही हूँ, because this is very important for your concepts, that you remember that यहाँ पे nicotinic N receptor है acetylcholine. Okay, अब जाते हैं ganglion से नीचे. So post ganglionic neuron in parasympathetic, you will have M1, M2, M3. So these are your cholinergic receptors. Let's get them out of the way. Tell me where they are. वेरी इजी वे टू रिमेम्बर, है ना, कि M1 सबसे पहले हमें, हमारे लिए सबसे इंपॉर्टेंट क्या है दुनिया में? खाना, राइट? वी वांट टू ईट. क्यों खाते हैं? ताकि दिल खुश रहे. सो दैट्स हाउ यू आर गोना रिमेम्बर दैट सबसे पहले खाएंगे. सो M1 रिसेप्टर्स आर ऑन द स्टमक. M2 रिसेप्टर्स कहाँ पे है? सो दैट आवर हार्ट स्टेज हैप्पी. सो दिस इज ऑन द हार्ट एंड एवरीवेयर एल्स. अगर पेट और दिल खुश है, बाकी सब खुश है, राइट? सो एवरीवेयर एल्स द रिसेप्टर दैट यू हैव इज गोना बी M3. That is what you want to remember. हाँ, गुजराती दिल खुश है और पेट खुश है तो सब खुश है, right? So stomach and heart everywhere else. All right. So now we go to the sympathetic system. The only thing here that is to be remembered is that even though sweat glands are sympathetic, isn't it? Sympathetic system से sweat gland आती है, but the neurotransmitter here is acetylcholine. So this is what you want to remember, that sweat glands are cholinergic sympathetic, right? So they are cholinergic sympathetic is what we have to remember from here. Baki norepinephrine आ सकता है. Mostly it is norepinephrine everywhere, which can act on all the receptors. You can have dopamine, and rarely from the medulla you can also have epinephrine. So these are all of your sympathetic system, which we will get to. Baki हमारा voluntary somatic system तो है ही, where you have neuromuscular junction and then you have acetylcholine, which is acting on NM receptors. All right. So this is nicotinic muscular receptors. So this is all about the very, very basics, right? अब जाते हैं into something which is again very conceptual and you must be knowing it. So when we talk about parasympathetic system, क्या हो जाता है? What are all the systems in our body which are active? If you remember dumbbells, you're going to be sorted for a lot of things in life. Okay. इसको conceptually भी समझ सकते हो, that anytime in parasympathetic system, you have to remember that every organ in our body, visceral organ, is going to relax. All right. So it's all going to basically relax, and in the sense sphincters are going to relax. They're all going to be very active. All right. Secretions are going to increase. So what is the parasympathetic outflow? Just remember dumbbells. Can somebody expand dumbbells for me? What is going to happen if parasympathetic is activated? Yes, GI बहुत सारा काम करेगा. Too much secretion, diarrhea. Urination, again, urinary bladder is relaxing, sphincters are relaxing, too much urination. M for very, very important, meiosis. We will come to this again. All right. So pupil पे बाद में आएंगे, but parasympathetic cholinergic is meiosis. Everybody knows. Heart, what happens to heart? Bradycardia. So heart is going to go down. Opposite of sympathetic. Bradycardia हो जाएगा. What about E? E for what is E? और bradycardia के साथ एक और भी बता दो. We will also have bronchospasm, right? We will also have bronchospasm. These are the two most important things that you have to remember here. E for emesis, you can also have vomiting. L for lacrimation, you can have too much tearing up, and S for salivation. Do you remember cholinergic tha, sympathetic tha, but cholinergic tha. So salivation also you will have. So this is your dumbbells, which is going to be very, very important, which tells you about the cholinergic outflow. So now, yeah, also you can remember from E, parasympathetic is erection, whereas ejaculation is sympathetic. I'm sure all of you know this, और इसको कोई याद करने की जरूरत नहीं है, right? So this is parasympathetic outflow. Now we talk about the pupil. So cholinergic, we have said, is meiosis, right? So what you want to remember about cholinergic is all things C will be active, है ना? So cholinergic मतलब pupil is gonna constrict. Yeah. So you remember C for cholinergic, C for pupil will constrict. Why does pupil constrict? Because which muscle is active? Can somebody tell me which muscle of iris is active here? Again, it will help you. C for circular muscles. When circular muscle contracts, you have pupillary constriction. And simultaneously, what happens when there is cholinergic outflow? The ciliaris muscle is also active, which allows you to accommodation, right? So this is very important, that C for cholinergic, will constrict the pupil, meiosis as we know, by circular muscle contraction and ciliaris. Similarly, जब मैं mydriasis बोलती हूँ, which muscle of pupil is gonna contract? It's gonna be the radial muscle. Dilator or radial muscle is what you want to remember. Dilator pupil ये तो काफी logical हो गया. So they will ask you radial muscle, isn't it? They won't ask you constrictor pupil because वो तो नाम में ही है. So you need to know constrictor is circular. Baki by default you'll remember dilator is radial. Okay, so all C's are sticking together. So can I say that when cholinergic pathway is active, there is active meiosis? है ना, मतलब meiosis हो रहा है, muscles are contracting, circular muscles are contracting and you are having meiosis. On the other hand, if I do anticholinergic, meiosis नहीं होगा अपने आप ही, passively, because cholinergic is blocked, mydriasis हो गया. तो इसको हम क्या बोलते हैं? We call it passive mydriasis. Yeah, understood this? Very logical, isn't it? Sympathetic में क्या होगा? Again, when sympathetic outflow comes, now radial muscles are gonna constrict. So what is gonna happen here? Now you're gonna have active mydriasis. And anti-sympathetic में, or basically अगर block कर रहे हो sympathetic outflow, what is gonna happen? Passive meiosis. So this, if you just remember like the concept, you will not need to memorize this. One more thing for I want you to understand is, if can you tell me accommodation bhi jayega? Ciliaris is also gonna go. So can I also write here that in addition, there is gonna be cycloplegia, which is happening? Yeah, I'm gonna highlight this because this is very important. That when I do anticholinergic or I give anticholinergic, passive mydriasis with cycloplegia. Now, let's say that I show you one eye. See my eye and imagine that it's mydriat. Basically, mydriasis ho raha hai. If I show you one eye jisme mydriasis hai, वो आई तो बताएगा नहीं that it is active or passive. How will you know whether it's sympathetic or anticholinergic? Then the trick lies with cycloplegia, isn't it? If you see it is cycloplegia is also there, means anticholinergic drug has been given, atropine has been given. But if you see that there is no cycloplegia, only mydriasis is there, means a sympathetic drug has been given. Did you understand this? That's the reason behind the importance of cycloplegia, right? So here they ask you that I can use two mydriatics. Normally we use two mydriatics. What are the two mydriatics? The two mydriatics are atropine and let's say phencyclidine. All right, so let's say we are using this and we are using any alpha sympathetic agent, right? Phenylephrine, right? So let's say we are using phenylephrine, tropicamide and atropine. In this, how will you distinguish? So atropine and tropicamide, both of them are anticholinergic drugs. So usme mujhe mydriasis with cycloplegia milega, whereas in phenylephrine, what I will get is no cycloplegia. So that is also a repeat question which has been tested. I hope you understood the concept. Cycloplegia is just you test accommodation. When you test accommodation, you will not see that constriction is not happening. All right, so this is what you need to understand. Now again, using the same concept, now you've understood that yeah, jab cholinergic bahut active hoga, there is gonna be, there's not repeating, just see this part again. All right, just see this part again. Basically it's the difference between sympathetic and anticholinergic. Agar cycloplegia hai to anticholinergic, agar cycloplegia nahi hai, only mydriasis is there, then sympathetic. Bas itna hi hai, one line. Okay, that is the only repeating that needs to be done. Yeah, more English. So now what you want to remember is, when you have too much parasympathetic which is happening, what would you suspect? Let's say somebody comes to you with dumbbells. So the two possibilities here would be, one is organophosphate poisoning. Organophosphate poisoning matlab cholinergic. People keep mixing this up all the time. So OP is acetylcholine esterase inhibitor, right? So what organophosphate is going to do is, it's going to cause a lot of cholinergic pathway, and so is early mushroom poisoning. Both of these are going to result in cholinergic manifestations. All right, so bas itna sa concept yaad rakho, you know the cholinergic manifestations, isn't it? So organophosphate, early mushroom, cholinergic, you are going to see meiosis which is happening. Can somebody tell me the drug of choice? So now it's just about the concept. Agar cholinergic hai, I have to give an anticholinergic drug. So that is atropine. Atropine is the drug of choice. In addition, what do I give to regenerate the acetylcholine esterase? I can also give pralidoxime, right? So I can also give pralidoxime, which is gonna cause regeneration of the enzyme. This regenerates the enzyme. All right, so this is what we need to remember here. Now, What about late mushroom? Just to finish off mushroom poisoning here, remember early mushroom is cholinergic. Late mushroom is not anticholinergic. No, that's not how it is. Late mushroom is just gonna have hallucinogen property. You are gonna have hallucinations. And what is important is here, atropine is contraindicated. Here, drug of choice is atropine. Here, atropine is contraindicated. That is what you want to remember here. Fine. No, nothing, no definitive drug of choice. It's conservative management that you have to do. The early mushroom में cholinergic manifestation. That is the additional point, because I'm sure you all know organophosphate is cholinergic. अब opposite, anticholinergic manifestation क्या हो जाएंगे? एकदम opposite manifestation. So the most important thing you are going to look out for are midriasis, right? What will happen to temperature? Can somebody tell me temperature ko kya hoga? You will have hyperthermia. You will have hyperthermia. You are not sweating, right? Sweating nahi ho raha, so you will have increased temperature. What else will happen? Every secretion is going to be reduced. So you're going to have dry skin here. You're going to have reduced tears. So all of the opposite things of dumbbells you just do tachycardia, opposite of dumbbells kar do, we will have the manifestation. So datura and Jimson weed, the manifestations are anticholinergic clinical features. And children, if suppose a child eats datura, you have to remember what is the symptom which is more common in children, because children don't have hypothalamus, which is very, very well centered. What is going to happen is children have more hyperthermia. Remember, out of all of these manifestations, if datura poisoning happens in children, there's going to be more hyperthermia. All right. What you want to remember? Drug of choice for datura poisoning. Ab batao, cholinergic drug dena padega. So what is a cholinergic drug? Yes, we give physostigmine because it can cross the blood-brain barrier. It is the only drug which can cross the blood-brain barrier. All right. Why is that so? I will tell you in a minute. All right. So this summarizes a cholinergic, anticholinergic wala thing for you very conceptually. Yeah. This table is clear. Everybody, aage bade. We have to increase our speed a bit. Now it's all about the drugs and their uses. So what are the cholinergic drugs? So here, either I can have directly stimulating cholinergic receptors, or we can have indirect. Indirect matlab kaun? Acetylcholine esterase inhibitors. Acetylcholine ko jo break kar raha hai, the enzyme breaking acetylcholine, we are inhibiting it. So obviously acetylcholine will be increased. So that is what is your indirect agonist. So these are all of your cholinergic drugs. How to remember direct are sabke naam mein. You are going to see CHOL. The name itself is going to tell you that it is a cholinergic. Pilocarpine is the only thing which doesn't tell you directly, तो हम indirectly निकाल देते. Look at it, COL. उल्टा जाएंगे तो नाम में COL है, right? Except for cevimeline. Cevimeline in no way is telling us that it is cholinergic, but it has a C. So in the first letter, it gave away that may be cholinergic. I'm also a C. All right. So all of these things will tell you with the name itself that I am a cholinergic, so that you don't get confused. Now going on to the uses. So bethenacol, B for bladder. So this is what is going to act on the bladder. So now tell me, cholinergic matlab it is going to cause contraction of the bladder, right? So this is what I use for atonic bladder. So here I'm just going to write the use. All right. So this is used for treatment of atonic bladder because cholinergic bladder contraction, urination karayega, right? So again, once you understand the concept, it becomes very easy. What does carbachol do? So here you want to remember this is used as a meiotic agent because it causes meiosis, and this is the one which is maximum nicotinic action. ये एक one liner है, which drug has maximum nicotinic receptor पे action? It is carbachol. Then we have methacholine. In respiratory system, we study this. Now, can somebody tell me what is methacholine used as? Very nice. This is used as a challenge test for the diagnosis of asthma. In an asthmatic patient, if I give methacholine, do you agree that there's going to be vasoconstriction? And in asthmatic patient, it's even more reactive. Its airways even more reactive. You will have even more constriction. So this is what is known as a methacholine challenge test, right? Do we do this normally? No, we don't do this normally. Normally, how do we test? कभी भी provoke करके test नहीं करना चाहिए. We should test by relieving. So what do? Yes, we will give salbutamol and we will see that there should be increase. By how much percentage can somebody tell me? अभी पढ़ा है medicine. Very nice. More than 12%. If the FEV1 by FVC or just the FEV1 increases by 12%, we know that it is asthma. It is reactive airway disease. Very good. Now we go to pilocarpine. Pilocarpine pilocarpine also we have studied in rheumat. Both of these drugs we have studied in rheumat. Which disease? Sjogren's, right? So for Sjogren's, what happens? We have dry eyes, dry mouth, and we know cholinergic is stimulating all secretions, so we use it for Sjogren's. Anywhere else where you have red pilocarpine, in ophtha we will study now. We will study pilocarpine in glaucoma, right? So this is also used in glaucoma. Particularly which glaucoma is this more useful in? It can be used in both, but it is very useful in angle closure glaucoma because it causes meiosis. Remember, mydriasis always is going to be very bad. It makes the angle even smaller. So we always want to give a meiotic. So angle closure and open angle both we use, but angle closure more particularly. Fine. So this is all about direct. Indirect, can somebody tell me? Don, Riva, Gala, ये कहाँ पे use करते हैं? Donepezil, rivastigmine and galantamine. These are all first line drugs for Alzheimer's, right? So these are the drug of choice for mild Alzheimer's disease. What is the drug of choice for moderate to severe Alzheimer's? It is memantine, right? It is NMDA antagonist, memantine, which is for severe. For mild, it is cholinergic drugs, because in acetylcholine what happens? What is the nucleus which is at fault? Again, concept. It is the basal nucleus of Mayer-net, right? It is the Mayer-net nucleus which produces acetylcholine, which is damaged. So that is why I have to give more acetylcholine. So concept yaad rakhoge to sab easy hai. What about neostigmine? Now all three stigmine drugs we need to remember. So neostigmine is our very, very important guy. Wonderful. Neostigmine I use after a snake bite. I use it for what all? I also use it for reversal of neuromuscular blockade, right? I can also use it for post-op ileus, है ना? Post-op ileus या फिर UB retention. I can use this. Now, what is very important is when I'm using it for snake bite or reversal of neuromuscular agents, I don't want the muscarinic action. I only want the nicotinic action, right? So what you want to remember is in May, I also need to supplement this with atropine. Atropine, remember, always blocks the muscarinic receptor. It never blocks the nicotinic receptors. N receptors ko block nahi karta. It only blocks the M receptors. So I will not have the cholinergic side effects here. Whereas post-op ileus and UB retention are acting by muscarinic receptors, M3 receptors. So I can't use atropine here. Got this? So this is for neostigmine. Then what you want to remember? Pyridostigmine. Pyridostigmine हमने neuro में पढ़ा है. This is the drug of choice for myasthenia gravis. Very nice. This is the drug of choice for myasthenia gravis. Both of these drugs do not cross the blood-brain barrier. What crosses the blood-brain barrier is physostigmine because it is a tertiary amine. That tells you that the others are quaternary. So this is a tertiary amine. It crosses because it is lipid soluble. And that is why, where do I use physostigmine? Abhi humne padha hai, we use it as a drug of choice for any cholinergic toxicity, which could be which could be, use it for anticholinergic, which is datura, right? So drug of choice for datura poisoning. So this is physostigmine. Then we talk about varenicline. Varenicline is a partial agonist. It's not an indirect, but a partial agonist. On what receptor? On the nicotinic N receptor. And that is why this is used as a anti-smoking drug, right? This we have studied in CNS system. So this is your anti-smoking drug, and this is your alpha 4 beta 2 receptor, if you want to know the complete name. ठीक है? Post-op के बाजू में लिखा है UB retention, post-op urinary bladder retention. ठीक है? So this is about cholinergic drugs. Now you also have, so these are all reversible acetylcholine esterase inhibitors. We also have irreversible acetylcholine esterase inhibitors, which are carbamates and organophosphates. तो ये खाली नाम के लिए I brought you, बाकी we have discussed this topic already, right? So you have carbaryl propoxyl, which are carbamates, and then you have all of these OPs. Just see the names. Sometimes we get confused with the names as well, and they've asked this in the past. The only thing is here you don't give oximes, you only give atropine. Here you do give oximes in addition to atropine. So the drug of choice for both is going to be atropine. Yeah, so far so good, everybody. This is what we have to remember here. एंटी स्मोकिंग के बाद लिखा है अल्फा 4 बीटा 2, सो इट्स एक्ट्स ऑन द अल्फा 4 बीटा 2 इंटीग्रिन ऑफ एन एन चैनल. ये उसका पूरा नाम है. यू डोंट हैव टू रिमेंबर, जस्ट रिमेंबर द 2 numbers. How to remember the numbers? Again, beta is second, right? So 2 2s are 4, alpha is first, so product should be 4. 1 into 4 and 2 into 2 equals 4. That's an easy trick bana lo na. It's so easy. Fine. So this is cholinergic drugs. Then we have anticholinergic drugs. So anticholinergic drugs, obviously OP anticholinergic is atropine. Then you have homatropine and tropicamide. So as I said, all of these I'm going to use for meiosis, right? Meiosis or midriasis. All of these I'm going to use for fundus examination when I need midriasis. And do they also induce cycloplegia or they do not induce cycloplegia? They do induce, because cholinergic was causing accommodation. When I give anticholinergic, it is going to induce cycloplegia. Cycloplegia, bachcho, means accommodation reflex is gone, right? So that is what these drugs are going to do. Atropine is the longest acting, so I don't use it. Person will have 2 din tak midriasis mein ghumega, so we don't want that. What do we use? We use tropicamide. Tropicamide is the shortest acting that you have. And what is very, very important, obviously, jo hum angle closure glaucoma mein use kar rahe the, this becomes a contraindication in angle closure glaucoma. So very, very logical contraindication here. What about benztropine and trihexyphenidyl? Where have we studied this in psychiatry? Can somebody tell me? Very good. This is the drug of choice for extrapyramidal side effects, right? Anticholinergic drug. So we give this for acute dystonia, isn't it? We give this for acute dystonia, drug-induced Parkinsonism. So this is where we are giving benztropine. Glycopyrrolate, where do we give? To reduce the secretion. Ab anticholinergic ho gaya, so this we give pre-operatively to reduce secretion, because anticholinergic will reduce secretions. Hyoscine and dicyclomine. Cholinergic, remember, was inducing emesis. Dumbbells mein E was emesis. So now can I give as an antiemetic an anticholinergic drug? Yes. So now it's also logical. So these are drugs that I use for motion sickness. What about ipratropium, tiotropium? Cholinergic cause bronchospasm. So can I use this as anti-bronchospasm? Yes. So you can use this as bronchodilators in asthma, and more importantly in COPD. We use them more commonly in COPD. What about soft D drugs? So here you will remember they make the bladder soft. Solifenacin, naam padna hi nahi, soft bladder. So soft bladder kar rahe hain means I will use them for overactive bladder, right? When the bladder is very spastic, overactive bladder ke liye, these will act as treatment. So you remember, soft D make the bladder soft. Okay. What about scopolamine? Again, scopolamine is something that we use for motion sickness. All right. This is something that we use for motion sickness. Again, what about pirenzapine? Pirenzapine is a specific receptor. Abhi tak sab kuch non-specific. M1, M2, M3, everything it is acting on. This is M1 specific antagonist. So this is what I use for peptic ulcer disease, right? This is what you want to remember. Finally, these are overall anticholinergic, wherein they reduce the secretion of acetylcholine at the synapse. Synapse pe hi secretion block kar dete hain. So BT, vesamicol, hemocolium. Do you remember BT toxin, botulinum toxin? It doesn't allow acetylcholine to be released, and that is why you have flaccid paralysis. This is the first thing we had studied in micro, isn't it? So ye hai hamara cholinergic and anticholinergic. Fine, तो ये तो अभी baby stuff है. Now we go on to beta agonist and antagonist. So again, everything जो हम anticholinergic में पढ़ के आए थे, everything is going to apply to sympathetic system. So here, now we have 4 receptors that we have to play around with. So you have alpha 1, alpha 2, beta 1, beta 2, and beta 3. All right. Before that, one question for you is, what is the difference between atropine and hyoscine? Any difference between atropine and hyoscine? So basically, remember that hyoscine causes more CNS depression. It is a bigger CNS depressant. And that is why what happens is, this is used as a truth serum. And you know, one more truth serum that we have studied is thiopental sodium. So thiopental sodium is also used as a truth serum that we have studied in anesthesia. This is one more truth serum, which is because it causes CNS depression, right? So this is what you want to remember. Correct. This is actually the bigger active principle in Datura rather than atropine. Even though we remember it with atropine, it's actually this, which is very, very important. Okay? Now let's go to alpha. So here, tell me, Where does alpha 1 act? What is the action of alpha 1 on blood vessels? Very, very important. Alpha 1 causes vasoconstriction. In the main BTR of general pharma, you must have studied, I have taught you vasomotor reversal of Dale, right? वहां पे मैंने क्या सिखाया है? That alpha 1 and beta 2. These are the two receptors that we have. Alpha 1 causes vasoconstriction, beta 2 causes vasodilatation. है ना? तो ऐसे करके आता है. This is what we want to remember here. So blood vessel, alpha 1, vasoconstriction. What does it do to pupil? अरे मैम समझ गया ना कॉन्सेप्ट. दिस इज मिड्रियासिस. कैसा मिड्रियासिस अगर समझ गया तो बताओ, एक्टिव मिड्रियासिस और पैसिव मिड्रियासिस? Active, right? Uska action hai, something is contracting. So this is active mydriasis. And what about urinary bladder? Just like anticholinergic drugs, right? Cholinergic was activating the bladder. This is going to cause relaxation of bladder. तो क्या मैं इसी से मैं contraindication बना सकती हूँ? Can I make contraindications of alpha blockers from this only? That I shouldn't give any alpha blocker, basically where all alpha blocker से क्या क्या हो रहा है? Or let's say we'll talk, all right, so let's just combine it. Where will you not give an alpha blocker? Alpha blocker will cause what? It will cause vasodilatation, right? So alpha blocker is going to cause vasodilatation, which is postural hypotension. It's going to cause postural hypotension. It will cause what? It will cause meiosis, which is not any contraindication, and relaxation of urinary bladder. So it is going to cause contraction of urinary bladder. It's going to cause a lot of sphincter relaxation. So again, one more side effect here in alpha blockers is going to be what? What is going to happen to the bladder? It's going to become very much contracted. So overactive spastic bladder is one more side effect or contraindication of alpha blockers that you can remember simultaneously. Okay, so this is about alpha 1. We'll talk about the names of the drugs in a while after I explain you the concept. तो अभी तक इतना समझ आ गया कि vasoconstriction, midriasis, relaxation of bladder. Let's talk about alpha 2. Alpha 2 is like an inhibitor. It is like a brake to the sympathetic system. So what you want to remember is that alpha 2 is actually a sympathetic system. It is like a brake is what you want to remember. It inhibits the secretion of adrenaline, sympathetic system overall. Okay, so alpha 2 will be stimulated. It will stop the sympathetic system. Now going on to beta 1. Beta 1 is mainly on the heart. Now beta 1 no stomach nothing. M1 में पहले stomach था. Beta में सबसे पहले heart, दिल का मामला. Beta 1 always heart. What does it do to the heart? It stimulates. It stimulates everything. It increases the heart rate. It increases the ionotropy, right? So chronotropy, inotropy, सब कुछ बढ़ा देता है. So this is beta 1 on the heart. Beta 2 is everywhere else that you want to remember. So we have already done what does it do to blood vessel? Vasodilation. What does it do to bowel, bladder, uterus? Again, everything relaxes. Opposite of cholinergic. What does it do to bronchus? Bronchodilation. है ना? Opposite of once I know cholinergic, I just have to do opposite. Does it increase tremor? Yes, it increases tremor. This is one side effect of beta agonist. And it also increases sugar, right? It increases the glucose level in our body by causing glycogenolysis. So this is very, very important. Again, with this only, I can actually understand the side effects of beta 2 agonist and beta blockers, isn't it? Agar mujhe itna samajh mein aa gaya. Beta 2 agonists are going to cause hypotension. They're going to cause tremor. They can cause hyperglycemia. Beta blockers will cause hypoglycemia. They will cause bronchospasm, isn't it? So this is how you can understand the side effects. What about beta 3? Beta 3 is only present in one place, which is urinary bladder. So you want to remember urinary bladder को relax करता है. And one more thing is lipolysis के लिए. This has been studied, adipolysis के लिए, right? So this is what you want to know about the receptors. Before I go into agonist, antagonist, या फिर अभी कर ले agonist, antagonist. पहले ये पढ़ ले. Shall we study the physiology here या सबसे पहले drugs? चलो, let's finish off the drugs first. Tell me what are the alpha 1 agonists? What are the alpha 1 agonists that you know? One is phenylephrine. So this is the simplest I could make because all of this was scattered everywhere. So this is how I can bring it together. So alpha agonist is phenylephrine, midodrine. So both of these, do you agree, are predominantly used as vasoconstrictors in shock? समझ में आ रहा है? एक्शन वेसोकंस्ट्रिक्शन है, दे आर यूज्ड इन शॉक, राइट? सो phenylephrine, midodrine. Midodrine particularly is used for postural hypotension. It is the drug of choice for postural hypotension. Does it make sense? जो अल्फा ब्लॉकर का साइड इफेक्ट है उसके लिए ड्रग ऑफ चॉइस इज अल्फा एगोनिस्ट. Yeah, so this is midodrine. Then let's talk about antagonist. What about alpha antagonist? So here let's go to this table. इस table में सारे antagonists है. The non-selective antagonists are your pheno drugs. So phenoxybenzamine, phentolamine. These are non-selective alpha blockers, alpha 1, alpha 2, both. Here, what do they do? Again, phenoxybenzamine, remember, is an irreversible. Phentolamine is a reversible blocker. उसके अलावा क्या याद रखना है? Phenoxybenzamine is used in pheochromocytoma. So this is used in pheochromocytoma because it is causing vasodilatation. It is blocking vasoconstriction, right? So that's why for hypertension of pheo, we are using phenoxybenzamine. Phentolamine, because it is reversible, it is used for chotu-motu things, right? So if you have a cheese reaction हो सकता है tyramine. There's a drug called tyramine. If you have clonidine withdrawal, we can use this. We'll talk about what is clonidine and it will make sense. We can also use it for cocaine overdose. Cocaine is again a sympathomimetic, so we can give this we can give phentolamine for this. Now let's talk about selective alpha 1 blockers. So these are again gonna cause vasodilatation, postural hypotension. So these are drugs which are all gonna end with in or sin. Sin is how you will remember. So do, pheno, non-selective. In wale are all selective ones. So prazosin, terazosin, doxazosin. What are all of these alpha blockers gonna do? So these are all basically gonna allow the urethra to have urine pass through it, right? So here what we are gonna remember is prazosin, terazosin, and doxazosin. These are all used for one, BPH. BPH के लिए use कर सकते हैं because they cause the relaxation of urethra. We can use them for hypertension because they are causing vasodilatation. Peripheral arterial disease because they cause vasodilatation. We can use it for scorpion sting. Very, very important. Scorpion sting causes an autonomic storm, isn't it? It causes autonomic storm, too much adrenaline to be released. So I will use this. So this is what you want to remember here. Now, what happens is with all of these drugs, there's a very important side effect, which is first dose postural hypotension, isn't it? As we have already discussed. Now, if I want to avoid it, scientists ने ये देखा that this postural hypotension is coming from one selective alpha 1, which is alpha 1 BD. And urethra के लिए I only need alpha 1A. So that is why we brought about a selective alpha 1A blocker. So the advantage of tamsulosin is the fact that this receptor is not acted upon. That is why there is going to be no postural hypotension, and that is why this is the drug of choice for BPH. Yesterday also we saw in FMG PYQs that this is the drug of choice, is the first drug you will give because this acts on the dynamic symptoms. It allows the urethra to have good urine flow. It acts on the symptoms, LUTS. Whereas if I want to act on the static symptoms, reduce the size of prostate, I will have to use anti-androgen drugs like finasteride, right? Finasteride is going to block the 5 alpha reductase enzyme. So ऐसे करके आप याद रख सकते हो. So this is tamsulosin here. Fine. So this is about alpha blockers. So alpha antagonist done in the table. Apart from that, you also have a few indirect agonists which are gonna increase overall. They reduce the reuptake of adrenaline. Overall, they act as sympathetic agonists. So एक तो amphetamine, cocaine, ephedrine. You know that cocaine causes a lot of sympathetic supply. Amphetamine causes a lot of sympathetic supply. Both of them are going to cause increased heart rate. Both of them are going to cause mydriasis, right? So this is how you can just remember. And ephedrine again causes increased blood pressure. You can use it for refractory shock. Okay, so these are your indirect agonists that you want to remember here. Now let's go to alpha 2. In alpha 2, what do you remember? That these are opposite, है ना? Sympatholytic है. So what are your alpha 2 agonists that you know? So one is clonidine. Very, very important, clonidine. Another is alpha methyl dopa. So can I say that both of these are actually going to be, even though they are agonists, they are going to be anti-sympathetic, right? They are going to cause vasodilation. And that is why I use both of these for hypertensive emergencies. Methyl dopa, I even use it for pregnancy-induced hypertension, right? So they cause vasodilation. And what is an antagonist? Just the name you have to remember. Yohi Maib, all right. So Yohi Maib is the alpha 2 antagonist. Just the name, iska koi khas use nahi hai. Okay. Then beta 1, very, very important. Who is beta 1 agonist, which is going to cause a lot of pumping of the heart? Beta 1 agonist you want to remember is dobutamine. So dobutamine is a selective beta 1 agonist. Do not get confused. This has nothing to do with dopamine. This is a selective beta 1 agonist. Dobutamine, जिसके नाम में dopa आता है, that is a dopamine agonist. Dobutamine has nothing to do with dopamine. That is one of the most commonly confused thing that students do, right? So this is what we use for cardiogenic shock, obviously, because it increases the pumping of the heart. Beta 1 antagonists are your selective beta blockers, which we will study, which selectively act on the heart. ये अभी हम पढ़ेंगे. Now let's come to beta 2. Everything apart from the heart is done by beta 2. What are your beta 2 agonists? Can somebody tell me? Focus on bronchodilator. I want good bronchodilator. So what are your bronchodilators? Correct. Salbutamol. Focus on uterine relaxation. Can I also use this for tocolytics? Yes, you can use them for bronchodilation. You can use them for tocolysis. So another example is terbutaline. So salbutamol, albuterol, terbutaline, ritodrin, all of these are your beta 2 agonist. Beta blockers. So these are beta 2 antagonist, all non-selective. But can you tell me one? Not very important as a drug clinically, but which is a selective beta 2 antagonist. Can you name that drug? Which is a selective beta 2 blocker? Very nice. It is butoxamine. So butoxamine के नाम में ही एक X है कि मेरा कोई काम नहीं है. Okay. Ami. In Bengali, Ami means man. Na to khud keh raha hai, Ami X. So butoxamine is how you will remember. All right, that I have no use. I'm just a one-liner. Okay, Ami X, one-liner. All right, that is what you will remember. Not nebivolol. Nebivolol pe आएंगे अभी हम. ठीक है. What is beta 3 agonist? Beta 3 agonist का नाम बता दो. हाँ, मेरा bladder gone, which is mirabegron. Right. So here you are going to remember mirabegron is your beta 3 agonist, all right, which relaxes the bladder. Fine. So this is all about your drugs. Is it seeming any better now? Right. So this is after a lot of thinking. Pehle mere 5-6 slides the beta blocker, alpha blocker. Then I just brought it like this. And I think this is much better conceptually. Now let's go to even bigger concepts. All right. So now we just have beta blockers. Let's just finish beta blockers and then we'll come to this concept. Yeah. Let's just finish beta blockers first. So beta blockers, as I said, you have beta 1 selective. So beta 1 selective are specific for your CVS uses, right? जो हम heart में हर chapter में पढ़ेंगे, hypertension में, CHF में, angina में, you'll study them everywhere. Because what do beta blockers do? They reduce the myocardial oxygen demand, isn't it? वो heart का काम कम कर रहे हैं. They reduce the myocardial oxygen demand, and that's why these are very good drugs. Now, how many of you have framed mnemonics and memorized mnemonics for remembering beta 1 selective beta blockers? You all have. I have. We all have, right? Now I'll tell you one trick which will disrupt all of that. You need not remember anything. So what you want to do is any name which is coming from A to N, any name which starts from A to N, that is going to be your beta 1 selective drug. Don't take it the other way around. So basically, anything which falls within A to N could be beta 1 selective, could be non-selective. But anything which goes outside N cannot be beta 1 selective. All right. So mnemonic mein bhi thoda concept hai that anything outside it, meaning nadolol can be non-selective even though it is an N. But no letter beyond N can come into selective. आगे समझ में all right, so that is what. बाकी अगर आपने न्यूमोनिक याद कर रखा है तो stick with it, but this is a very good trick which I found because I tend to forget those sentences जिनको expand करके खोलना होता है. In the exam you never remember, right? So you can just take a guess that अगर A to N में आ रहा है, it is likely to be beta 1 selective. Fine, but again I haven't seen this question, you know, such questions getting asked now. All of the following are beta selective except. ऐसे drugs अब कोई ऐसे questions कोई नहीं पूछता. Anyways, so these are the drugs. Let's see what is special. What is special about esmolol? It is the shortest acting beta blocker and it is metabolized by plasma esterase. This we will write again. Okay. What is very special about nebivolol? Very special about nebivolol is it starts from N and N के लिए क्या याद रखना है nebivolol से? Correct. It causes nitric oxide release, right? So it is causing NO release and that is why it is also partial vasodilator. All right. So it's also a vasodilator. Oh, नीचे लिख दिया. Sorry. So it also releases NO and it is also vasodilator. Then what is very special about celiprolol and acebutolol? AC दोनों में ही AC से याद रखो IS. What is very similar to ANC? INS, right? So INS is very similar. So you'll remember these also have intrinsic sympathomimetic activity. Now look at the irony. These are beta blocker drugs and they also have partial intrinsic sympathomimetic action. So basically, why are we using them? Na idhar ke na udhar ke. Why are we using them? Because they will not cause very severe bradycardia. Other drugs will reduce the heart rate too much, which can cause sometimes very severe bradycardia, isn't it? But Celi and acebutolol, they are not going to cause severe. So you can see how bradycardia is a contraindication. So in such patients, I can use this because इनके पास दोनों action. It has some sympathomimetic, it has some blocker. Both, दोनों काम कर लेता है. All right. So that is what you want to remember. AC से IS कैसे याद रखना is a very good question. So let me explain. A is a vowel, I is a vowel. C is sir and sir is sir, right? So that's how they are very similar. How can you not understand this? Okay. So this is how you will remember. Fine. So this is celiprolol and this is acebutolol. Now let's go to non-selective. Non-selective में है nadolol. What is nadolol की खास बात? Anybody can tell me nadolol की खास बात? It is the longest acting beta blocker. Okay. ठीक है. So ना ही दो, इतना चलेगा कि ना दो. Longest acting. Then we have propranolol. Propranolol, if you don't remember anything, it will be propranolol. So propranolol is the drug of choice for all things other than CVS. So other than CVS and glaucoma, if they ask you what will you use? Performance anxiety, thyroid storm, akathisia, prophylaxis, essential tremor, इन सब में ही हमारा drug of choice कौन है? Propranolol. ठीक है. Timolol कहाँ यूज आएगा? One thing is left, glaucoma. So for glaucoma, we use timolol, not very commonly, but timolol is one of the classic drugs that used to be used for glaucoma. Pindolol की खास बात क्या है? Pindolol से याद रखना है that this also P for partial IS activity, intrinsic sympathomimetic activity, right? So you have AC and you have P. So कितना अच्छा है actually. Just add P also, no? So PAC causes PIS, right? So that's how you can actually remember. Yeah, open angle. Okay. Alpha plus beta blockers कौन है? We have carvedilol and labetalol. So this is CL, carvedilol and labetalol, which are alpha plus beta, meaning they also cause vasodilation, isn't it? Alpha blocker भी है, they also cause vasodilation. What is in addition extra property of carvedilol? It is also an antioxidant agent. Okay, so this is why carvedilol very good drug. What about tilisolol? कोई बता सकता है tilisolol क्या कर रहा है? It is also an additional potassium opener. And what is sotalol? It is also an additional potassium closer. Okay, potassium blocker is a better name. All right, so you can remember potassium opener, open ka spelling bhi galat hai, opener, and potassium closer drug, right? So that is what you can remember here. Fine, so this is about tilisolol and sotalol. So what can you predict about sotalol? If it blocks potassium, what did we study in CVS concept? Anything which is a potassium blocking drug, it's going to increase the QT interval, right? So this is also one of the drugs with prolonged QT. ठीक है, देखो कितना अच्छे से कॉन्सेप्ट से यू आर प्रिडिक्टिंग साइड इफेक्ट्स. दैट्स हाउ फार्मा इज टू बी स्टडीड. ओके, नाउ गोइंग ऑन टू contraindication. So again, because it's reducing the heart ka pumping action, I won't use it for brady and AV block. I won't use it for somebody who has exacerbation. I won't use a an anti-inotropic agent for somebody with acute CHF. So these are heart contraindications. Apart from that, asthma. Why? Again, concept. जो भी cholinergic था, can I say, would be actions of beta blockers, whatever was pro-cholinergic effect, because it's just crossing, isn't it? So asthma, I will not give. Peripheral vascular disease, vasoconstriction कराएगा, I won't use. Diabetes mellitus, because we just saw that beta का action होता है to increase glucose. So beta blockers I will not use because it will mask all of the signs of hypoglycemia is what you want to remember. Then Prince metal angina, because again vasospasm, vasoconstriction it can do. What would be the drug of choice for toxicity of beta blocker? Not calcium channel, glucagon. All right, very, very important question. Can't get it wrong. So this is how you want to remember all of the side effects. Very nice. Only sweating with beta blockers would be seen. It will mask all of the other symptoms. Why only sweating will persist? Only sweating will persist because this is a cholinergic manifestation. It will not be blocked by beta blocker, right? So that's where sweating helps us. Baki glucose nahi bana paega. Patient will not have any tachycardia. Everything is being blocked by the beta blocker, right? So this is how you will remember. Now let's go to very, very important concept. इसमें अगर आपके concept ठीक नहीं है, you will never get these dog के BP के experiments correct. And nowadays this is the trend wherein maximum questions come from this. Okay, glucagon drug of choice for toxicity. Okay, chalo. Now let's go here. What is the action of dopamine at different levels? So you will remember DBA. BBA तो सुना होगा सबने, आज DBA सुनो. All right, so now from BBA you will remember DBA. All right, so what is DBA? DBA first action at very low doses acts on the D1 receptors. What is the action? Dabba is even better. All right, so D1 पे क्या याद रखना है? That D1 causes renal vasodilatation. GFR बढ़ा देगा, renal vasodilatation. What at 2 to 10? Alpha 1 है ना, sorry DBA है तो पहले DBA लिख लो, D, B and A. Now write 1 1. All right, so D1, B1 and alpha 1 is the action. Beta 1 पे act करेगा, what will it do? We have seen that it acts on the heart, it will increase heart rate. Alpha 1 पे act करेगा, it will increase BP, it will cause vasoconstriction. So do you agree ये बढ़िया drug है? It is increasing the heart rate, it is increasing the BP also. So very useful in cardiogenic shock. But even better, nobody else can do this. It will also increase the GFR. While constricting other vessels, it will also cause GFR increase. So this is the best drug. Nothing can beat it. किसी के पास ऐसा action ही नहीं, super power ही नहीं. So dopamine is the best drug for cardiogenic shock with oliguria. Does that make sense to all of you? Yeah. So this is there. What are the other drugs which act on dopamine receptors? So I told you, right? Not dobutamine. Dopa नाम में आना चाहिए. So dopexamine and phenoldopam. Dopam नाम में आना चाहिए. So these are both acting on D1. Dopexamine acts on D1, B1 and B2. All of these, right? So D1, B1 and B2. And this is why I use it for shock. Not very, very useful. Phenol, because alpha pe action nahi hai, right? So that's why we don't really use it. Phenoldopam is only D1. D1 only. So this is also something that we can use. Because this is causing renal vasodilatation, no other action, I can use this for hypertensive emergencies, isn't it? Where I want to increase the blood flow to the kidney. So these are the uses of these two dopamine drugs. अब जाते हैं into very, very important concept which I have explained in the main video also. Tell me, what receptor does norepinephrine love? सबसे preferential action किस receptor पे होगा for norepinephrine? It acts on everything, but most preferential is alpha 1. It is a predominant vasoconstrictor. So it acts on alpha 1, alpha 2 more than beta 1. So this is the order. What about epinephrine? Epinephrine loves beta. Epinephrine is beta more than alpha. And what about isoproterenol? It is only beta. So beta 1 equals beta 2. No alpha action, right? Now, very important concept. Right now, nobody will sleep. Everybody will pay attention. Systolic blood pressure, who is the main regulator? It is beta 1 receptor. All right. It's the heart which regulates the systolic blood pressure. Diastolic blood pressure is regulated more by alpha 1 and then beta 2. Remember the vasoconstriction, vasodilatation, all of that is diastolic blood pressure. And heart rate is one and only who? Beta 1. So this is how you need to remember कि किससे क्या change होगा. So now let's take an example of norepinephrine. What does norepinephrine do predominantly? Alpha 1 means it does vasoconstriction. So can I understand that norepinephrine definitely is increasing the diastolic blood pressure? Yeah. Does norepinephrine do much to the systolic BP? Beta 1 तो बहुत late आ रहा है. So it is not increasing the systolic too much, but it is definitely increasing the diastolic blood pressure, right? And what about the heart rate? If the BP increases, that is what it relatively is doing. It is increasing the blood pressure. What do you think will happen to the heart rate? Uska koi direct action to hai nahi. Direct action is way down the line. So it will cause a reflex bradycardia. Very, very important. Norepinephrine, the buzzword for your exam. No other drug will do it. Reflex bradycardia. So look at this graph. Now it will make sense. What is it doing to the diastolic blood pressure? It is increasing via action of alpha 1. It is mildly increasing the action of mildly increasing the systolic by action on beta 1, which is very late in its curve. So it is increasing overall both of the pressures, and resultantly there is reflex bradycardia. Understood this? So norepinephrine, only thing, one thing, agar samajh nahi aaya, one thing you remember, norepinephrine is a vasoconstrictor. It is a wonderful drug for shock. It is predominant action is it increases the blood pressure. Look at the overall effect. Overall, it is increasing the mean arterial pressure, but it is causing reflex bradycardia. Cardiac output को वो कुछ नहीं कर रहा, right? So this is what is very concept. अगर concept थोड़ा सा समझ लोगे तो ये difficult नहीं लगेगा. थोड़ा सा कोशिश करो दिमाग से concept लगाने की. What I'm teaching only, पुराना concept भी नहीं. Right now you build concept. Okay, that alpha 1 is vasoconstrictor and norepinephrine is acting on alpha 1. So it is increasing the overall BP. If you can't understand systolic, diastolic, just remember one thing. Norepinephrine, net increase in BP, heart rate will reduce. इतना समझ में आ गया? और कितना टाइम क्लास चलेगी? अभी तमन्ना को कॉन्सेप्ट समझ नहीं आ रहा था और अब क्लास कितना चलेगी? नेक्स्ट इज epinephrine. Next question is epinephrine. Now what you have to understand is beta more than alpha. What you want to remember here is, इसीलिए concept समझ नहीं आया, because you want to focus कि class कब तक चलेगी. You are not present in the moment. Time देखना ही नहीं चाहिए कितना टाइम हुआ, 1 घंटा हुआ, 2 घंटा हुआ. समझने की कोशिश करो तो फिर समझ आएगा, है ना? अगर घड़ी देखोगे तो कहाँ से concept समझ आएगा? Fine? Okay, now come back. So now we are going on to epinephrine. What is epinephrine doing? Predominant beta, isn't it? So what will it do to systolic blood pressure? It will increase. What will it do to diastolic blood pressure? This is where the magic comes in. Now it is going to be preferentially vasodilator. तो यहाँ पे देखो क्या हो गया, diastolic blood pressure कम हो गया, DBP reduced whereas systolic blood pressure increased. तो क्या हो जाएगा पल्स प्रेशर का? Pulse pressure will also increase, right? Pulse pressure will also increase, and overall, because it has a very big beta 1 action, what will happen to heart rate? Heart rate will increase. तो समझ में आया बच्चों कि इसमें BP बढ़ेगा, and खास बात क्या है? Systolic BP बढ़ेगा, diastolic BP कम होगा, and what will you have in heart rate? Heart rate will increase. Understood this everybody? This is epinephrine for you. इससे easy नहीं कर सकते यार इसको. And finally, third is isoproterenol. Isoproterenol का खाली beta action है, so obviously this is gonna be vasodilatation. So now look at this, diastolic BP reduces, systolic stays as it is. Systolic में बहुत minimal action आएगा, systolic will also increase, diastolic will reduce, and what is very important again, there is gonna be reflex tachycardia, because overall here the blood pressure is reducing. Iso में there is no vasoconstriction happening, there is no alpha 1, so overall the blood pressure is reducing more towards the range, and that is why you have reflex increase in heart rate. Okay, so this is about the 3 graphs that I'm showing you. They can ask you about this. Okay, so what you want to remember are the receptor actions. अभी भी समझ नहीं आया? दिस इज हाउ क्वेश्चंस विल कम. नाउ लुक एट इट. ओके, कोई बात नहीं, समझ नहीं आया, अभी समझ आएगा. ठीक है, अगेन गिव मी योर कंप्लीट फोकस. Epinephrine, do you agree, has both of the actions? Yeah, epinephrine has alpha 1 and beta 2 both. So what will happen? Alpha 1 is vasoconstrictor, beta 2 is vasodilator, ABCD, right? So which is more sensitive? More sensitive is vasodilation, but more prominent is vasoconstriction. So when I just give epinephrine at high dose, there is going to be vasoconstriction and then there is going to be vasodilatation. यहाँ पे alpha 1 act करेगा, यहाँ पे beta 2 act करेगा, and this is known as the biphasic response of adrenaline. This I have taught you in the main video also. What will norepinephrine do? उसके पास खाली alpha action है, no vasodilatation. So it will only increase the blood pressure. What will isoprotenolol do? It has no alpha action, only beta 1, beta 2. So it will cause vasodilatation, BP will reduce. आ गया समझ में ये? अब देखो मजे की बात. Now look at this graph. All three of them I have. Epinephrine you saw कि कम होगा फिर बढ़ेगा फिर कम होगा. Noradrenaline बढ़ेगा, isoprotenolol कम होगा. So this is normal. Now when I give alpha blocker, tell me what will happen to epinephrine when I give alpha blocker? Do you agree that this will not happen only? Only vasodilatation will happen. This is what is known as vasomotor reversal of Dale. That even though epinephrine, the drug you say is the strongest vasoconstrictor, is now causing a drop in BP. You see this? And this is what we call as vasomotor reversal of Dale. Upon giving alpha blocker, epinephrine changes its action. This is a beautiful image because it is telling you everything. What will happen to noradrenaline when I give a beta blocker? नॉरएड्रेनालिन को कोई खास फर्क पड़ेगा? नॉरएड्रेनालिन एनीवे, सॉरी, नॉरएपिनेफ्रिन को क्या होगा? नॉरएपिनेफ्रिन प्रीडोमिनेंटली हैज दैट अल्फा ब्लॉकिंग एजेंट, राइट, बट इट डज नॉट हैव वेसोडाइलेटेशन, right? So I will not have a very marked reduce because there is no beta 2 which is waiting that the moment alpha will get blocked I will take advantage. यहाँ पे तो beta 2 ने advantage ले लिया ना, it reduced the BP, but here there is no beta 2, so BP will not increase. BP is not increasing as it should have been, but now nobody is taking advantage. Understood this? And finally, do you think isoprotenolol cares? Alpha blocker से उसको तो फर्क ही नहीं पड़ा. There is no action on alpha, so it will show no change. Yeah, so this is so beautiful. If you understand the concept, you will understand this graph. Now let's go to the scene where I give beta blockers. I am giving beta blocker after giving epinephrine. एपिनेफ्रिन में अगर बीटा ब्लॉकर देंगे, व्हाट विल हैपन? नाउ अल्फा 1 विल टेक एडवांटेज कि भाई करो, वेसोकंस्ट्रिक्शन करो. इट विल इंक्रीज द बीपी, isn't it? It will cause a lot of increase in the blood pressure. What about norepinephrine? Norepinephrine के पास क्या था? Predominant alpha 1 action was anyways there. Even if you give beta blocker, it doesn't care कि ठीक है, I will do my alpha 1 action. It is again causing increased BP. Now, who will suffer the most? Isoprotenolol had only beta 1, beta 2 action. वो भी आपने block कर दिया. So now look at this. There is no vasodilatation. There is no drop in blood pressure, right? It will not increase, but there is no drop. आया ना मजा? So the only thing that you have to now understand is the receptor that they act on. Yeah, one more time if you will listen to this, you will understand. Okay, अगर नहीं समझा तो fine. Now two more very interesting questions. They give you this graph and they tell you what is the phenomenon which is being depicted. पहले दे रहे थे तो बढ़ रहा था, and suddenly now the response is going. What is this called? Very good. This is what is called as tachyphylaxis. And tachyphylaxis means repeated dose पे the response reduces, and this is what we see for ephedrine. All right. So जो indirect agonist का table नहीं था, indirect agonist का table, ये सब हमारे tachyphylaxis show करते हैं. Repeatedly it will show this. Okay. Now एक बहुत मस्त fact. Look at this. Tell me what acetylcholine will do to the blood pressure. What will it do to the blood pressure? Or what will it do to the heart rate if I ask you? Heart rate को क्या करेगा? BP छोड़ दो, heart rate को acetylcholine will do what? It will decrease, right? So acetylcholine we had seen as opposite. So acetylcholine is going to cause a drop in the heart rate. Let's say I give, okay, तो इतना समझ में आ गया that it is causing dropping in the heart rate of the patient. What will happen when I give atropine to the patient? What do you think should happen technically? If I give atropine to the patient, heart rate should increase. Why? Why is the heart rate increasing? So look at this. What is happening when I give atropine? The acetylcholine cannot act on the muscarinic receptors, right? As the acetylcholine cannot act on the muscarinic receptor. So what happens is acetylcholine will only act on the nicotinic receptor. So it acts on the nicotinic receptors and it increases the catecholamine release. So this is why there is an increase in the heart rate. That is why there is an increase in the heart rate upon giving acetylcholine after giving atropine. Did you understand? So normally acetylcholine is causing drop in the heart rate. But after giving atropine, if I give acetylcholine, technically तो उसका कोई effect नहीं होना चाहिए था. There should have been no effect, right? There should have been no increase or no reduce. But what happens is the nicotinic receptors are still active. So when I again give acetylcholine, now what will happen? Do you see this? This is why I explained you this concept. The sympathetic release increases, because all of the other muscarinic are blocked. So acetylcholine is like, अब मैं जाऊं तो जाऊं कहाँ? What should I do? I am free. So then it goes and activates the sympathetic system, and that is why you have increase in heart rate here. Okay, so this is the reason why you have tachycardia after giving atropine with acetylcholine. Okay. Okay, so this is about the ANS system. So now we are done with the toughest part. It took longer than I expected, but still, like, I think 1 hour for these 4 chapters, it hasn't been explained, like under 4 hours anyway. So I've included almost every detail. So itna kar loge to bahut hai. Every question should be answered hopefully, because this is all concepts, right? Isme ratne ki koi baat hi nahi hai. This is all that you have to understand. Kaun sa table reh gaya? Yeah, so very, very important, drug of choice now. So again, what would be the drug of choice? The main vasoconstrictor कौन है मेरे पास? Alpha 1 पे जो mainly act कर रहा है. So what acts mainly on alpha 1 is norepinephrine, right? So I want to give norepinephrine to a person who is in shock. Then cardiogenic shock. When the heart is not pumping, what should I give? I should give a beta 1 agonist. Who is our beta 1 agonist? Dobutamine, right? So dobutamine is the drug of choice for cardiogenic shock. But when there is oliguria, we have already established dopamine. What about anytime you want to do CPR, anaphylactic shock? You know it is epinephrine. We know the doses as well, right? Postural hypotension के लिए drug of choice क्या है? Postural hypotension means any alpha agonist I can give, right? So any alpha agonist I can give, it is midodrine, which is the drug of choice for postural hypotension. And spinal induced hypotension, spinal anesthesia se hypotension, the other agonist we give, which is phenylephrine. Okay, fine. So this is a very, very useful table again for all of your one-liner questions of adrenergic drugs. Okay, yeah, this will be available in BTR. Okay. Right, now let's go to autocoids. So now we have autocoids to do, and then we have NSAIDs, and then a few general pharma tables, and then general path. Okay, so in the next 20 minutes, we'll finish off pharma, and after that, we will do 20 more minutes path. So 40 more minutes you guys can study. 6 o'clock tak free kar dungi, and so much we would have covered. Okay, is that fair enough with everyone? All right, 6 o'clock tak pakka se class will be over. Okay, all right, chalo, let's study autocoids now. So in autocoids, what you have to study are, there are 3 kinds of autocoids from the very concept. You have peptide, amine, and lipid. Peptide autocoids, as the name suggests, is wherever they are secreted, that is where the action is. Jo jisko chahiye wahi release karega, wahi cell release karega. So peptide is angiotensin and bradykinin. Okay, so these we study in renal system, right? So bradykinin and angiotensin are your peptide autocoids. Amine autocoids are जिसके नाम में ही इन आता है एंड में. So serotonin and histamine, the 2 drugs that we are going to study now, anti-serotonergic and Histaminix. Lipid is the next section we are going to study, prostaglandins and leukotrienes. ठीक है, अब जाते हैं histamine पे. Histamine mein, again, if you know the receptor action, just 2 tables, 2 chapters finished. So H1, what is the action of the H1 receptor? This is your main histamine receptor. This is what mediates allergy. And this is what also importantly mediates wakefulness. So now does it make sense that when I block H1, allergy to chali jayegi, anti-allergic, but it also causes sedation, right? It also causes sedation. So your H1 blockers are all of these drugs that we are going to study. So when I say antihistaminics, I mean anti-H1 drugs, right? So we'll talk about this in a moment. H2 पे क्या action है? This is what releases acid in the stomach. So I use this for peptic ulcer disease. So what are your typical anti-H2 blockers here? All of your tidine drugs, right? So your cimetidine, ranitidine, all of these are your drugs which are your H2 blockers. Perfect. H3, just like how we had alpha 2 receptors who were a break in sympathetic system, H3 is your break in histaminic system. They're going to block. So now, antagonist are basically inverse agonist. Do you remember the graph from general pharma? Where this is complete agonist, this is partial agonist, this is antagonist, and this is inverse agonist. So now inverse agonist has the opposite action. तो अगर हमने ब्रेक को ब्रेक कर दिया तो there will be too much activation. Do you agree? दुश्मन का दुश्मन दोस्त, it's like that. So H3 की ब्रेक को अगर आपने ब्रेक कर दिया, you are gonna have increase in the wakefulness, can I say? You're gonna have more histamine getting released, you're gonna have more allergy in a way, right? So you're gonna have more wakefulness. So this is one drug only with two names. This is how pharma is. Okay, तो दोनों ही मुश्किल नाम. Pitolisant and tiprolisant, two names they wanted. So these are going to increase wakefulness. So these are new drugs that have now been proposed for narcolepsy. आया ना समझ में? So this is what is that. And H4, what is H4? H4 का कुछ खास काम नहीं है. It is what regulates chemotaxis, है ना? अभी पढ़ेंगे chemotaxis. Fine. So this is about this. Now let's go to antihistaminics. हाँ, modafinil है, but this is a new drug. Okay, modafinil is the drug of choice for narcolepsy. मान लिया, but this is new drug. Okay, चलो. First generation and second generation. Difference क्या है? First generation antihistaminics have a lot of anticholinergic side effects, right? So they have a lot of anticholinergic side effects. They cross the blood-brain barrier, and that is why they have a lot of sedation, which is not there in second generation. This thing, okay? Won't H3 block cause allergy? So it's block only. Inverse agonist मतलब antagonist ही समझ लो conceptually, right? It is block only. Inverse agonist is like antagonist only. Okay. All right. ठीक है. तो मैंने क्यों क्लोरफेनिरामिन और प्रोमेथाजिन को हाईलाइट किया है? What is the trade name of क्लोरफेनिरामिन जो आपने सुना ही होगा, कहीं ना कहीं दी ही होगी किसी ना किसी को? This is Avil. What you need to remember from Avil क्लोरफेनिरामिन is this is the least sedating ड्रग, सबसे कम सिडेशन इसमें होता है. व्हाट इज प्रोमिथाजिन? ये भी कभी ना कभी तो किसी को दी ही होगी. दिस इज फिनार्गन. ऑलराइट, सो दिस इज फिनार्गन व्हिच इज प्रोमिथाजिन. ऑलराइट, अगर मैं बीटीआर लूं और आपको फिनार्गन और एविली ना बताओ तो कैसे डॉक्टर बनोगे? ऑलराइट, सो दिस इज व्हाट यू वांट टू रिमेंबर. एंड दिस इज द वन व्हिच इज मैक्सिमम. दिस इज द वन व्हिच क्रॉसेस ब्लड ब्रेन बैरियर मैक्सिमम. ठीक है, दिस इज योर ओनली सोर्स. इतना तो पढ़ा के जाऊंगी. ओके, यू कीप आस्किंग, नो मैम इज दिस इनफ? तो एग्जाम के लिए तो इनफ होगा, बट लाइफ के लिए भी इनफ करना है तो एविल फिनार्गन तो बता ही जाती हूँ. ऑलराइट, सो दिस इज एविल एंड फिनार्गन. Fine. So this is about first generation antihistaminics. Now we go to second generation antihistaminics. तो इसमें बहुत सारे नाम है. You must be knowing most of these drugs. What is special about the color in blue? Okay, you are practitioner. Very good. So what is the special thing about color in blue is these are called as third, मतलब ऐसी जबरदस्ती का third generation है. These are metabolites of second generation drugs. All right. So desloratadine then is the metabolite of loratadine. Fexofenadine is a metabolite of terfenadine. ठीक है. And levocetrizine तो सबको पता ही है. Come on. Levocetrizine is a metabolite of cetrizine, right? So these are third generation which have relatively lesser sedation. So these are all metabolite drugs. So that is about blue. Rupatadine कौन है? Rupatadine also has platelet activating factor inhibition. तो ये थोड़ा सा स्पेशल बात है. What is very important about estemizole and terfenadine? और लेट मी ऐड वन मोर ड्रग, सीसाप्राइड. ये कैट ड्रग्स में ऐसी क्या खास बात है? These cat drugs are all metabolized by CYP3A4. All of these cause QT prolongation and इसीलिए हमने इसको मार्केट से निकाल दिया. These have been withdrawn from the market. Cisapride अभी आएगा. When we go to serotonin, it will come. Estemizole and terfenadine are your cat drugs. Okay, cat is QT.
पैरामेडिक्स। देखो कितना प्यारा चैप्टर 2 डब्बे में हो गया। नाउ वी गो टू सेरोटोनिन, अगेन 1 डब्बा, वी आर डन विथ 1 चैप्टर. So 5-HT1A, what is 5-HT1A doing? 5-HT1A is again your presynaptic inhibitor. It is also a presynaptic inhibitor. Just name the drugs here. What is your 5-HT1A agonist? ये हमने पढ़ा है न्यूरो में, साइकी में, करेक्ट. दिस इज ब्यूस्पाइरॉन. किस कैटेगरी में आता है ब्यूस्पाइरॉन? दिस इज एंटी एंजाइटी ड्रग्स. ओके, सो दिस इज एन एंटी एंजाइटी ड्रग. इसको किससे कंफ्यूज नहीं करोगे, डोंट कंफ्यूज इट विद ब्यूप्रोपियोन. ब्यूप्रोपियोन इज एन एनडीआरआई. लिख दूं यहाँ पे, ब्यूप्रोपियोन NDRI, right? Also an anti-smoking drug, isn't it? Buspirone is anti-anxiety. ठीक है, fine. 5-HT1B1D, ये भी हमने न्यूरो में ही पढ़ा. Everything comes in neuro here. So this is what causes vasoconstriction in the brain. So the agonists are your triptans and your ergot drugs. So they cause vasoconstriction, and that is why drug of choice for migraine termination, isn't it? Acute attack of migraine are your triptans. Okay, not ergot, please. ठीक है, fine, because they cause vasoconstriction. Then 5-HT2A2C. 5-HT2A2C antagonist कौन है? It is your atypical antipsychotics. Do you see how we are in the CNS chapter? So atypical antipsychotics, do you remember that they don't really have dopaminergic blocking ability? They have anti-serotonergic ability. So this is what you need to remember. What was the main side effect of atypical antipsychotics? Metabolic, right? They have weight gain. So do you agree that if I give agonist, so we thought that अच्छा block करने से अगर weight gain हो रहा है, if I activate this, there might be weight loss. So what is the drug which is now being used as a weight loss agent? It is locaserin. So locaserin has been used as an anti-obesity drug. Got this? Now let's go to 5-HT3. 5-HT3 तो बहुत important. This acts on the CTZ, right? So it acts on the trigger of the MSS zone. So 5-HT3 antagonists are all of your cetrons. So what are the cetrons? Ondansetron, granisetron, all of your cetrons that you need to know. These are the drug of choice for post-op vomiting, for post-chemo vomiting, for post-RT vomiting. These are your drug of choice. What is the side effect? The side effect is that it causes QT prolongation. Yeah, we don't really use this anymore. It has been banned. Yeah, we don't really use it, just the name you want to remember. What are the drugs which are approved as anti-obesity? I have a list which I will show you. Okay, so this is causing QT prolongation, right? So this is one very important side effect. They also cause constipation. Very, very important. Fine. 5-HT4 is a prokinetic receptor. So what are the 5-HT4 prokinetic agents that you know? अभी cisapride पढ़ रहे थे. So cisapride, all of your prides, mosapride, tegaserod, all of these are the drugs which are used as a prokinetic agent. These are used for GERD, and one more thing is they also cause QT prolongation. ये भी QT वाले हैं. ठीक है? So this is about your serotonergic drugs. ठीक है? तो एक टेबल में सब कुछ हो गया. Fine. Okay, आगे बढ़े. Now let's go to prostaglandins and NSAIDs. Here, what is the pathway? So phospholipid से arachidonic acid and फिर हमारे सारे prostaglandins बन रहे हैं. Can I just block this enzyme? Can I block phospholipase A2 enzyme here? What would be that drug that is the ultimate OG anti-inflammatory drug? Correct, it is steroid, right? So steroid use कर लो, but मुझे नहीं करना, मुझे non steroidal anti-inflammatory चाहिए. तो we're like, okay, fine, अब नीचे पढ़ो तो फिर. So then cyclooxygenase is what is bringing PGG to PGH2, right? तो हमने बोला कि ठीक है, cyclooxygenase को block कर देते हैं. So then we have all of the COX inhibitors like aspirin and NSAIDs, but these are non-steroidal. So these are your mission accomplished non-steroidal anti-inflammatory drugs, COX inhibitors. Fine, let's go down further. Now this prostaglandin H2 can give rise to F2 alpha, E1, E2, I2, TXA2. This is where I have done maximum hard work in compiling all of these drugs. It was not given anywhere in one place. I don't know why. So यहाँ पे मैंने बहुत मेहनत लगाई है, इधर उधर से सारे prostaglandins इकट्ठे करे हैं. So what you need to remember, first is PGI2 TXA2 balance समझ लो. What is producing PGI2 and what is producing thromboxane A2? So thromboxane A2, as the name suggests, is A for aggregator. It is an activator of platelet aggregation. तो कौन बना रहा होगा? No prize for guessing. Who promotes platelet aggregation? Platelet promotes platelet aggregation. So this is produced by platelet. PGI2 is an inhibitor of platelet aggregation and it is also vasodilator. Who produces this? Endothelium produces it, right? So now my question to you is, why is aspirin an antiplatelet agent? It is blocking both, right? It is blocking platelet aggregator also and it is blocking platelet anti-aggregator also. So what happens is this platelet cannot regenerate. उल्टा ना, प्लेटलेट कैनॉट रीजेनरेट. एंडोथेलियम के पास सेल है, प्लेटलेट हैज नो न्यूक्लियस, नथिंग. वो तो एक बार अपने मम्मी से दूर आ गई, इट कैन नेवर डू एनीथिंग. बट एंडोथेलियम हैज अ लॉट ऑफ न्यूक्लियस एंड इट कैन डू एवरीथिंग. सो एंडोथेलियम कैन रीजेनरेट. सो दिस इज व्हाई डू यू अग्री दैट एस्पिरिन हैज अ नेट anti-aggregatory effect? Yeah, understood this? So this is about PGI2 TXA2 balance. Now comes the very easy part. So PGI2 prostacyclin इसका नाम है, is also called basically you have to remember is a vasodilator, as I said. What are the names? Iloprost, epoprostenol and selexipag. As the name suggests, all of these prostaglandins have the name pro in it. No surprise, there'll be pro in it. Selexipag के पास pro क्यों नहीं है? ये डोज नहीं जानना. डोज आई विल टेल यू. ऑफ एस्पिरिन यू आर सेइंग, आई विल टेल यू. वेट, later on. So selexipag में क्या है? Selexipag में what you need to remember is actually not a prostacyclin analog. It is actually a prostacyclin agonist. Okay, so this is the first point, agonist. And this is the only drug I can give orally. बाकी दोनों ही I give IV. Where do I want to give all of these vasodilators? I want to give it in pH. So these are all used as vasodilators in pH. So these are 3 PGI2 analogs. Clear everybody? Now PGE2. PGE2 तो हमें पता ही है from OBG. Dinner for two. Do you all remember? Dinoproston. So this is used for, where is this used? Yes, cervical ripening. This is used for induction of labor. This is the only one which has no role in what? No role in PPH. इसका dinner for two का कोई role नहीं है PPH में. Something I discovered here, that dinoprost and dinoproston are different. How many of you knew this? I never knew this before today. So dinoproston and dinoprost are two different things. Okay, so this is where you can get confused. That dinoprost is actually PGF2 alpha, but dinoproston is PGE2. Okay, you knew? Okay, that's good for you. So dinoproston is what is not used in PPH. Okay, but dinoprost is used. Okay. मुझे भी लगा था सेम ही होगा यार, इतना पूरा पूरा नाम तो मैं कभी नहीं पढ़ी आज तक. आई हैव नेवर रेड फुल नेम्स ऑफ ड्रग्स ओनली. आई ओनली रेड फार्मा फॉर एमसीक्यू पर्पस एंड टुडे आई फाइंड दैट ओ पूरा पढ़ना जरूरी था फॉर दिस. ओके, सो डाइनोप्रोस्टॉन एंड डाइनोप्रोस्ट इज डिफरेंट. फाइन, सो दैट्स हाउ यू कैन रिमेंबर. या, इट एंड्स विद एन ई. दैट्स अ गुड ट्रिक. एंड्स विद एन ई, सो दिस इज E2. फाइन. अब आते हैं PGE1 पे. PGE1 पे अल्प्रोस्टाडिल. सो दिल से याद रखो, दिस इज फॉर PDA. इट इज फॉर कीपिंग डक्टस आर्टेरियोसस पेटेंट, लाइक थिंग्स लाइक TGA. You've used both names interchangeably before because I didn't know only, no Sneha. I am admitting I didn't know they were two different things. All right. So PDA is important in keeping, which is TGA. All right. So this is TGA. And I assume from now on that my knowledge is equivalent to yours. मतलब मुझे जितना आता है उतना आपको आता है, मुझे जितना नहीं आता वो भी तुम्हें नहीं आता. So whatever additional information I find out, I'll make sure I keep giving you. That ये कुछ नया आया है मेरे दिमाग में. You guys should know. Okay. So this is alprostadil, which is TGA के लिए we use it for keeping the PDA open. Then alprostadil, one more thing. So what you also you need to remember, what is the other use as a vasodilator? This is also used for erectile dysfunction. Okay, so this is how you can remember. Okay, next we go to misoprostol. Misoprostol में क्या याद रखेंगे? ये तो पता ही है. This is for induction of labor, augmentation of labor, PPH, everywhere you will use. Lubiprostol also is a PGE1 analog. This not many people have taught actually. Lubiprostol हम use करते हैं constipation में, right? So this is also PGE1 analog. Okay. What is latanoprost? Latanoprost पता है? What is the mechanism? Somebody will tell me. Latanoprost mechanism in glaucoma. What does it do? Drug of choice for glaucoma. What glaucoma? Open angle glaucoma. It increases uveoscleral outflow. राइट. सो वेरी वेरी इंपॉर्टेंट क्वेश्चन. इसके साइड इफेक्ट्स भी बहुत इंपॉर्टेंट है. हाइपरट्राइकोसिस, हाइपरक्रोमिया इरिडिस एंड सिस्टोइड मैक्युलर इडीमा. 3 साइड इफेक्ट्स. Okay. Carbopros, dinopros, this we know from PPH. And what is very important, these are contraindicated in asthma. So these are all of your prostaglandins in a nutshell that you need to know about. E1 hai, E2 hai, right? So if you remember dinner for 2, I think everything else gets sorted. Fine. Now let's come to LOX. So LOX के inhibitor को क्या बोलते हैं? What is the name of the LOX inhibitor? Xyluton, right? So xyluton is the lipooxygenase inhibitor. बाकी हमारे पास leukotriene antagonists है. So what are the leukotriene antagonists that we have? All of your montelukast and all, जिसके नाम में भी AST आता है. Zafirlukast, montelukast, they are antagonists. So you get LOX. These are only useful in asthma. Fine. Now let's go to all of the NSAIDs one by one. So these are your NSAID classification. So here, first, you have non-selective COX inhibitors which block COX-1, COX-2. So you guys know the concept of COX-1 and COX-2. COX-1 is something that I have everywhere, right? So it is something which is present everywhere, and that is what is present most importantly in the stomach, right? It is what is responsible for producing mucus which protects against peptic ulcer disease. So when I inhibit COX-1, what is going to happen is they have a side effect of peptic ulcer disease. So we were like that, okay, let me actually inhibit just COX-2, which is causing inflammation. This is what is causing inflammation. So we found out selective COX-2 inhibitor. So they are very useful because they have very less risk of PUD. इसीलिए तो हमने ब्लॉक करा. हाँ, डार्क पेन. बट व्हाट इज द साइड इफेक्ट? वेरी वेरी इंपॉर्टेंट. दे हैव हाई इंसिडेंस ऑफ MI. दे वर लाइक, ओके, तुम्हें पेप्टिक अल्सर नहीं चाहिए, फाइन, MI से मरो. So they have side effect which is even more serious. हम पेप्टिक अल्सर बचाने गए, मायोकार्डियल इन्फेक्शन से मर गए लोग. So this is the side effect. That's why they never got popular. When have you ever prescribed etoricoxib in your life? You haven't, because patient will die of MI. So we are still using other things. Okay. So this is about the classification. Now let's go to the individual drugs. Very very important. OG NSAID, aspirin, right? So aspirin, remember all of the points that you need to know here. First thing, it is an irreversible inhibitor, right? It is an irreversible COX inhibitor. So here you have various doses at which it is going to act. So 75 mg to 325 mg, it is going to have antiplatelet effect. This is where we most commonly use, like we saw, right? Antiplatelet. 325 से लेके 650 तक, it will have anti-inflammatory action. Okay, and more than 650, around 2 to 3 grams is when it is actually gonna have, sorry, इस पे antipyretic. Okay, 325 to 650 antipyretic, and 2 to 3 grams is when it actually has anti-inflammatory action, right? So these are the different doses at which aspirin is used. So most of the times we are only giving it at this dose, right? 75 to 325 mg. So now the various important points about aspirin, because there is no space left here. Do we give this in children? We don't give it in children because of the risk of Reyes syndrome. Another syndrome where aspirin is associated is the Samter's triad. Aspirin hypersensitivity हो सकती है. So 2 questions that you need to remember. अच्छा, you have prescribed? Okay, कोई बात नहीं. So Reyes syndrome, Samter's. देख लेना patient जिंदा या नहीं. Okay, then you have hyperuricemia. So it can cause hyperuricemia in low doses. आपने पढ़ा होगा that it causes uricosuric, right? It is a uricosuric drug, but at very high doses it is uricosuric, and that is why this is contraindicated in acute gout. ये मैंने पढ़ाया है. 2 things you will never give in acute gout: aspirin and PCM, isn't it? So we will not give because it causes hyperuricemia. What metabolic disturbance will it do? Earliest side effect is hyperventilation. So that is why it causes respiratory alkalosis, followed by it causes, it's salicylic acid, right? That's why it causes metabolic acidosis. So this is very important. Respiratory alkalosis followed by metabolic acidosis. Okay. I don't know why screen is blurred, because I have not done anything, like no optimization today. It should be fine only. Okay. And so what is the drug of choice? Metabolic acidosis. So we give sodium bicarbonate. All right. So these are all of the questions that you need to know about aspirin. Fine. Very, very important. Then we have ibuprofen. What do you need to know about ibuprofen? Ibuprofen is now the drug of choice for closure of patent ductus arteriosus. If you want to close, ibuprofen. Controversy hai ibuprofen versus indomethacin. Ibuprofen is better. All right. And also one more point is, this is the most common cause of aseptic meningitis. कभी सुना है ड्रग कॉजिंग एसेप्टिक मेनिंजाइटिस? मैंने पहली बार सुना. अगेन ibuprofen. All right. So ibuprofen is the drug of choice, better than indomethacin. Okay. फिर पिरोक्सिकैम की क्या खास बात है? दिस इज द लॉन्गेस्ट एक्टिंग एनासिड. longest acting NSAID. Okay. कर रहे होंगे prescribe, but it has higher risk of MI. Just remember that much. Okay. We don't really prefer it too much. Fine. Then ketorolac. Ketorolac की कोई खास बात बता सकता है? This is the NSAID that you can give IV. Acute pain में हम दे सकते हैं, right? IV. Remember, ibuprofen we can give it for, this is not in pregnancy. PDA बच्चे में ना, बच्चा is born and he has patent ductus arteriosus. To close it, we will give NSAID because prostaglandin is keeping it open. Okay. So baby is not in mother, baby is out. Then we are giving. Okay. So this is ketorolac. Indomethacin. Indomethacin की खास बात क्या है? It can cause a lot of sedation. It is the drug of choice for acute gout. It is also the drug of choice for Bartter syndrome. Very, very important. Bartter syndrome के लिए हम NSAIDs देते हैं. ठीक है? So this is what. How aseptic meningitis? Nobody knows. It's one side effect, rare side effect. Okay. So highlighted के one lines you just do. Okay. Ketorolac can be used for IV very rarely. Okay. Now, the most important OG drug, paracetamol. So paracetamol you can see has very poor anti-inflammatory action. So PCM, I'm sure all of you have taken PCM at least one in the last week only, let alone in your life. And इस हफ्ते में तो ली होगी. So that is paracetamol, the most commonly used agent, right? So what do you need to know about PCM? First of all, this is the safest drug in children. This is the safest drug in renal failure, right? Because now they think that it is acting on one new COX only. It is a COX-3 inhibitor, all right, which is only active in the CNS. It has no peripheral action. इसलिए बहुत safe है, right? But what is the biggest unsafe thing about it? The biggest unsafe thing is it gets metabolized to form NAPQI. No need to have the full form. It is basically causing this, which is causing hepatic centrilobular necrosis. The mechanism is centrilobular necrosis with periportal sparing. Okay, so NAPQI is causing, and that is why it can cause hepatic necrosis. The drug of choice against PCM toxicity has been asked so many times, N-acetylcysteine, right? So N-acetylcysteine is what we give. What else do you need to know about this? बस इतना ही काफी है. More than 250 mg per kg पे टॉक्सिक हो जाता है, which translates to around 10 grams of PCM. Fine, yeah, you have the King's College criteria for acute liver failure, जिसके लिए PCM is a very important cause. Fine, so these are the questions on PCM. We have a few preferential COX-2 inhibitors like nimesulide and diclofenac, but we don't really use it because of, again, this is hepatotoxic. Of MI, Itori is the longest acting COX-2 inhibitor. ठीक है, इतना कर लोगे? This is what you need to remember now. So this takes care of this. Now, very quickly, we have only 5 minutes to finish off 3 slides of general pharma. Sorry, 4 slides of general pharma. ठीक है. So which are the drugs which have high first pass metabolism? So this is the list. So that is why इनका इतना high है, we never give this orally. Remember, first pass metabolism is only applicable on what route? Only applicable on oral. So that is why these are never given orally. And these are also drugs, propranolol, morphine. These are very high first pass metabolism, and that is why we have to give a very high oral dose. Oral दे सकते हैं, but a very high dose is given. So just know the dose here, or just know the list here. The drugs given by transdermal patch, very, very important. Nicotine patch, सबको पता ही है, we give it for smoking. Tell me, hyoscine patch is used for, hyoscine and diphenhydramine patch. These are used for motion sickness. Very, very important, right? This is extremely important, that out of all of your anticholinergic drugs, which is the only transdermal patch, not any other scopolamine or nothing, it is only hyoscine. So ये सवाल आता है, will you remember this? So hyoscine causes motion sickness. Nitrate, we use it for angina, है ना, transdermal patch. Clonidine as a transdermal patch is used for hypertension, right? You can use for hypertension. Selegiline is used for depression. Depression में use करते हैं, ठीक है. Then rivastigmine as a transdermal patch comes for Alzheimer's disease. Ritogotin patch is used for Parkinson's. Parkinson's में मैंने पढ़ाया भी था, it comes as a transdermal patch. And HRT का patch आता है, right? So estrogen and progesterone comes as a patch, because these are again having very high first pass metabolism. Glucocorticoid, mineralocorticoid, can't give it orally. Fine. So this is one list. What? Okay, fentanyl patch also fine, added to the list. Volume of distribution. What is volume of distribution? In one line you can remember, this is the extravascular spread. So when I ask you now that if a drug has very high plasma protein binding, will it have high volume of distribution or low volume of distribution? Correct. So can I just write that it is inversely proportional to the volume of distribution? जितना प्लाज्मा को बाइंड करेगा उतना प्लाज्मा में रहेगा, it will not go anywhere else. So it is inversely proportional. On the other hand, if something is lipid soluble, it will cross membrane, it will go everywhere from the vessel. So this is directly proportional to the volume of distribution. Very nice. So what are the drugs which can undergo hemodialysis, which are all bound to the plasma, right? So what you want to remember what you want to remember here for hemodialysis are all of these drugs. Very, very important list. So barbiturate, lithium, alcohol, salicylate. So particularly you can remember aspirin here and theophylline. These are drugs which can be removed by hemodialysis. Very, very important list. Which drug has maximum volume of distribution? Answer is chloroquine. And that is why you remember it goes everywhere. It can go into the eye, cause bullseye maculopathy. It can go to skin, cause erythema multiforme, right? So 2 target lesions by chloroquine is what you want to remember here, right? So that has the maximum volume of distribution. This is so important, I can't tell you. This I have covered in forensic also, but I'm repeating because of its sheer importance. Where will you do an alkaline diuresis? For acidic drugs or for alkaline drugs? Basic drugs. We will do it for acidic, right? So ulta karna hai. Acidic drugs ke liye we are going to do an alkaline diuresis. With what do we do this? We do it with sodium bicarb. Abhi pad ke aaye hain. Sodium bicarb is the drug of choice for aspirin. So now what is the trick here is any drug which ends with 8 is your acidic drug. So salicylate, salicylic acid, acidic drug. Methotrexate. Did you guys know this 8 वाला concept? मुझे लग रहा है मैंने ही discover करा है. And third is barbiturate, because I didn't hear anybody say it. ये मुझे अचानक से घंटी बजी थी. हाँ, you have not heard it. No, I just realized it while I was making the list. So salicylate, methotrexate, and barbiturate. These are drugs which are actually acid. It's very obvious, no? It's in your face, but somehow nobody has seen it. Or maybe they have. So acidic and 8. Fine. So these are your acidic drugs. Then the forced acidic diuresis would be for basic drugs. So this would be for basic drugs. And what is it that you give for acidic diuresis? You're going to give ammonium chloride. Ammonium chloride देंगे. ठीक है. Even TCS? Yeah. तो इसमें कैसे करेंगे? 8. TC8. Just add a small 8. Okay. After A. Fine. So then you have forced acidic diuresis. Forced acidic diuresis would be drugs which are all ending with enes. Okay. So enes se khatam ho rahe hain. Like atropine, strychnine, quinine. Yeah, this is so nice. What else? Morphine, amphetamine. Anything that ends with an ene is going to be acidic diuresis. Fine. So this is very, very important. Okay. Right. What are the drugs which undergo acetylation? Acetylation is a phase 1 or a phase 2 reaction. Anything where new compound is added is phase 2. So this, you know, these are your ship drugs, right? So ship drugs. So sulfonamides or sulfa drugs, H for hydralazine, I for isoniazide, P for procanamide, and D for dapsone. Any other thing which it's common to all of them is all of them cause drug-induced lupus. What is the antibiotic? So not what is the antibody for DLE? Pharma itna dimag mein घुस गया, antibiotic ही याद आ रही. Antihistone, right? So this is antihistone. Fine. Okay. Then what are the drugs which cause gynecomastia? Sabko pata hai disco drugs, right? So what are all the disco drugs here which cause gynecomastia? So you have D for digoxin, I for INH, S for spironolactone, C for cimetidine, K for ketoconazole, and O for omeprazole. This is also list जो अपने आप ही बढ़ जाती है, you know, like अपने आप बढ़ जाएगी. You will remember in the exam. So this is disco drugs. What are the drugs which are ototoxic drugs? Not very like पता ही होगा. Cisplatin. What else is ototoxic? Loop diuretics, vancomycin, aminoglycoside, amphotericin B, NSAIDs. ठीक है. So one more thing I forgot to tell you about aspirin is aspirin causes tinnitus, right? So do remember aspirin toxicity का एक side effect होता है tinnitus, right? हाँ, ठीक है, इतना याद रखो. Ethacrynic acid also, very nice guys. Ethacrynic acid, that's why we don't really use it. Okay. What are all of the drugs which are pro drugs? तो ये पूरा लिस्ट है, इसमें से याद रखो. ACE inhibitors are pro drug except lisinopril. All right, so except lisinopril and captopril. So यही ऑप्शन में दिया होगा. Okay, all of the others are pro drugs. What are the drugs metabolized by plasma esterases? I have already told you this answer. Which drug is metabolized? Esmolol. That is why shortest acting. One more drug here is remifentanil. That is why remifentanil is also very short acting. What are the drugs? What is the drug metabolized by pseudocolinesterase? Only one, succinylcholine. Hoffman elimination, atracurium, cisatracurium, and that is why these are safe in renal failure and liver failure, right? Drug of choice. And what is preferred over atra and cisatra? Cisatra is preferred. Why? Because atracurium produces laudonosine, which causes seizures. ठीक है, रिमेंबर. फिर फार्माकोजेनेटिक टेस्टिंग हम किस ड्रग के लिए करते हैं? वेयर वी नीड टू सी वेदर दीज थ्री एंजाइम्स आर प्रेजेंट और नॉट. सो TPMT फुल फॉर्म मत याद रखना. This is used for, so this is a methyl transferase enzyme which is used for the metabolism of azathioprine and 6-mercaptopurine. वीक और से बता दो किसके लिए चेक करें? CYP2C9 whether it will be metabolized or not. Correct, warfarin. And DHPD is used for 5-FU. So these are basically the enzymes metabolized. So we need to see कि आप में वो enzyme है या नहीं. Only then we will give these drugs. Very important. What are essential drugs? These are drugs जो हमें चाहिए. The disease is so prevalent that you need it in the supply at all times. So they have to be cost effective. They have to be available easily, and very important, you can't have combination. This is what comes as the wrong option, that they are commonly available as fixed drug combination. No, you don't want to make them combination because again the price will increase, right? So that is what you want to remember here. Then counterfeit drugs में 3 category है where you need to know the meaning. Can somebody tell me what is a spurious or a falsified drug? Spurious or a falsified drug is, अब ऐसे हिंदी में कुछ भी बोलोगे, चुराया हुआ ड्रग, ऐसा नहीं. What happens here is, let's say you bought 500 mg of PCM and you see the drug and you find that there is 0 mg PCM. All right, so कुछ है ही नहीं, 0 mg दवाई. What is misbranded? Let's say you buy 500 mg PCM and you test the drug and you find कि अरे इसमें तो 200 mg PCM ही है, आधा ही डोज दिया. So that is what is known as misbranded. And adulterant is where you have added some extra substance, right? One harmful substance has been added, that is adulterated. So these are the 3 things that you want to remember. Okay, so ये है spurious falsified. ऐसे अनअकैडमी को फेक मत बोलो भाई, वो भी मैंने ही लिया है, लिया तो मैंने ही है ना, तो ऐसे मत बोलो यार. Misbranded ठीक है, but spurious मत बोलो. Alright, so that's spurious, misbranded and adulterated. Fine, so that is what you need to remember. Okay, now let's go to anti-obesity approved drugs. So anti-obesity approved drugs में क्या क्या है? तो ये सारे लिस्ट याद रख लो एक बार. टोपिरामेड एंड जोनिसमाइड, इनमें कुछ खास बातें हैं. These are anti-epileptic drugs which have both side effect of secondary open angle glaucoma. They both have side effect of renal stone, and they both cause weight loss, and both we give as combination with other drugs. Okay, so इनका कुछ लेना देना है, but again see हम एक साथ दे भी नहीं रहे because then side effects will also increase. So we give this with phentermine. Phentermine is a sympathomimetic drug. Bupropion, remember bupropion is what? बस इतना बता दो, serotonin वाला या smoking वाला? I will understand rest. Good, smoking वाला. Liraglutide, semaglutide. These are GLP-1 analogs, also cause SOAG, secondary open angle glaucoma side effect. Very important. Repeat question है ना, आईने का question है. GLP-1 analogs. What is tirzepatide? Tirzepatide क्या है, कोई बताएगा इसका mechanism? This is also something which is a common. Liraglutide पे 3 question थे. हाँ, anti. This is very very important, right? So here what you remember is this is also a combined GLP-1 analog with a very nice. Somebody has given answer. GLP-1 plus GIP analog, right? So this is combined. Orlistat and cetylistat are your lipase inhibitor, है ना? Oral lipase inhibitor. So these are the approved drugs. बाकी सब market से हटा दिए गए हैं. Fine. Drugs for sickle cell anemia. These are the 4 which have been approved. Glutamic. Why glutamic? Because what is the mutation in sickle cell anemia? Glutamate goes and valine welcomes. So we give glutamine. Hydroxyurea, because it increases hemoglobin F. Voxelotor and crizanlizumab reduce the sickling. I have a gut feeling that you will get a question on this. All of the following are used in sickle cell except. All right, so you need to know this list. इसमें कुछ ना कुछ अजीब monoclonal antibody they will put instead of crizan. So you'll remember crizan. Okay, PYQ है ये. Very good. ठीक है. So amifostin. So these are all drugs which we give in cancer, right? We're giving these in in cancer for certain causes. So now you will tell me what are the uses here. Amifostin किसके लिए दे रहे हैं? Yeah, this is a free radical scavenger which I give for cisplatin, है ना? Cisplatin की nephrotoxicity कम करने के लिए. Dexrazoxane is what? It is an iron scavenger and I use it to reduce the cardiotoxicity of anthracyclines. Isn't it? Doxorubicin ka. Leucovorin is what I give with methotrexate because it acts like a tetrahydrofolate precursor. Mesna binds to acrolein. Acrolein is the compound that is responsible for hemorrhagic cystitis because of cyclophosphamide. Filgrastim and sagramostim. So filgrastim is a granulocyte colony stimulating factor. इसमें MO आ रहा है. It is a GM colony stimulating factor, monocyte stimulating factor, given for neutropenia in cancers. EPO is an EPO erythropoietin stimulant for anemia in cancers. Oprevelkin is what? This is a repeat question. This is IL-11 analog, right? Again to increase platelet. Whereas romiplostin, platelet stimulator. L-trombopag, remember thrombus नाम में आ रहा है. These are TPO, thrombopoietin agonists. Okay, so these are all questions that can come from anti-cancer के anti-drugs, anti-cancer drugs. Okay, lastly we have schedules and categories. जो highlight करा है उतने schedule ही पता होना चाहिए. At least you should know difference between schedule and category. The question that has come here is schedule H. What is schedule H? It should only be sold under prescription. उसमें एक symbol होता है RX करके. Only under prescription. G means you have to give under medical supervision. Under in hospital you will do. J is category of drugs which cannot be treated, like drugs for HIV AIDS, drugs for diabetes mellitus, right? So diabetes mellitus, HIV, unke drugs come under schedule J. What is schedule P? P gives right about the life period and storage. P से period याद रख लो. ठीक है. X is what? X are your abusive drugs, drugs which have addictive potential, like barbiturates and all. So these are given with a copy here. What you have to remember is these are kept. The records should be kept for 2 years by the pharmacologist, and Y is for clinical trials. ठीक है. तो है तो इतने सारे, but these are the ones that you need to remember. इससे काम चल जाएगा. What you need to remember is schedule is not the same as category. Most of the students confuse schedule X and category X. This is for pregnancy. So categories is for pregnancy, wherein A is completely safe, B, C are thoda problematic, D is completely problematic, X is contraindicated. So you know the list. We have done this in OBG. What are category X drugs which are having teratogenic effects? So this completes pharma. What to do? You want to continue? You want to continue because it's already 6 o'clock. Tomorrow to nahi. Tomorrow कर सकते actually. Should we do 1 hour tomorrow? We finish in 1 hour. Next 3 days I have free. After that I have daily classes. Or किसी और सब्जेक्ट के साथ करें? Shall we do tomorrow? Tomorrow's fine. Because today will become too much, I think. Already it's been 2 hours. Let's do it tomorrow. 1 hour में हो जाएगा. This is just tables फटाफट. हाँ, चलेगा? Shall we do it tomorrow? I think most of you will agree. Tomorrow 5 o'clock is fine. Tomorrow Saturday, no? I'll let you know. Tomorrow or maybe Sunday. It will either be tomorrow or on Sunday, 5 o'clock, right? 5 would be the time. खत्म करा कल कर लेंगे, है ना? So we'll have 2 different sessions also. Okay, chalo fir padho, and then we will meet tomorrow day after, and then we will discuss what is to be done. Okay, all right. I hope pharma was good. It is something that I had dreaded for the longest time, that I'll have to teach general pharma in ANS, but I think it went well, and I'm now relieved that khatam hua. Okay, all right. So thank you so much, and we'll do path as a different session. And अब क्या class है is 2 तो FMG के PYQ session ही है. Then we have pediatrics which is lined up. After that we have derma, ENT, ophtha, psyche. So all short subjects are there. Okay. ठीक है. Zaru, I don't know, she's sleeping probably. आवाज नहीं आ रही. Let me see. I think she's sleeping. Do you want to wait? या फिर कल ले आऊं? Strategy, the strategy session will be there on 2nd. I'll take on 2nd August. Till then, let's just complete this subject. So how many of you have given, have joined new? How many of you are new here? So if you are new and you have not followed the previous schedule, right? What you can do is just continue from what we are doing now. Just say today we finished everything general, right? So next is pediatrics that we're starting off from tomorrow. So just start from peds now. 15 तक साथ में रहो. Till 15th, just be with this and follow this schedule and do the subjects. Then I'll tell you how to catch up. Okay, I'll give you a new schedule, but till then just be with this schedule, or do whatever you want. If you're already on a schedule, you can follow that. Otherwise, let's just talk dedicatedly. We'll talk and we'll find a new plan for everybody. Okay, so don't worry, but if you want, you can just stick with, so that you can follow the new bonus classes. Okay, ठीक है. चलो फिर अब मैं somebody is telling मैं मत जाइए. क्या करूँ, यही बैठी रहूँ. Let me check Zara. Okay, you guys study and I will see if she's up. He just woke up. Hi Zaru. Zaru baby. देखो baby है. Hi baby. Oh baby. Oh baby. Hi baby. Light. Yes, that's light. All right. Okay, thanks so much. Bye. Bye. Bye baby karo. Can you do bye? Baba sheep. Baba sheep. All right. Okay guys, thank you. Bye.